We have 4 JAK inhibitors approved for the treatment of MF in the United States. Prithviraj is not approved yet outside the US. And the 4 do differ significantly. For example, they don't all have the same targets. There are differences between how much they hit JAK1 and JAK2, whether they hit other targets, etc. The line of therapy is not stipulated in the labels. They can all be used across lines of therapy. And then the side effect profiles are also different. But a few key points I'll make are that Ruxolitinib and Fedratinib, the first 2 approved, are better suited for patients with proliferative disease, which means more robust blood counts, larger spleens, than patients with cytopenic or myelodepletive phenotype, which is the smaller spleens and, more importantly, lower blood counts. Ruxolitinib in particular is a dose-dependent drug, where you really need to optimize the dose for the best efficacy, and that is hard to do when the counts are low. So that is something that can influence treatment choices. Now, Ruxolitinib does also have the best demonstrated survival benefit. In fact, I will argue it's the only one with a clearly demonstrated survival benefit. Now, that could be a class effect. It could be that the other trials, some of which were impacted by clinical holds or compared the drugs to other JAK inhibitors, perhaps didn't get a fair shot at showing the survival improvement. But the data are the data, and what we have right now is that Ruxolitinib has by far the best demonstrated survival benefit. So I do take that into consideration. Again, the dosing issue that I mentioned, it's important to dose it well. And if you cannot really dose it well, then maybe you should look at a different drug. In fact, there have been some parameters proposed, or not just proposed, actually shown to adversely impact survival based on how you do during the first 6 months of Ruxolitinib. So if your dose is less than 20 milligram twice a day, if you're needing transfusions the whole time, if your spleen doesn't shrink by at least 30%, these are not good. They don't augur well for the future, and those patients don't do as well. So maybe we should be switching them. Now, do we know that switching them makes that better? We don't know that. But these are some of the considerations there. Now, for the others, I'll quickly say Fedratinib is good, in my view, for second line and beyond, as long as the counts are preserved. I don't see a good reason to use it in frontline. I don't see an advantage over Rux, and it has some additional baggage in terms of toxicity that Rux does not have. Momelotinib and Prithviraj are good for cytopenic patients, like I said. Momelotinib, I think, is better for anemia of the 2, frankly, the best of the 4. For anemia, it also has spleen and symptom benefits. So that is one that could be used across front and later lines, more used in later lines. And then Prithviraj is a drug that can be given despite really low blood count. So that is the go-to drug for patients with platelets less than 50. Momelotinib too has been studied down to 25, but it can cause some thrombocytopenia, and really it's not been studied in that many patients with severely low platelets, and therefore in those patients with really very low platelets, I use Prithviraj. For anemia predominant presentations, I prefer Momelotinib.